Thank you very much for the presentation. Very nice presentation. I'm here. I'm very glad to stay here also. Thank you to Roche for supporting this symposium. And I will start to, as the title says, managing pediatric SMA patients with Evrysdi, but I'm going to do some particular things about the medication in this case and my disclosures in this other case. So we know, and most of you know, practically the SMA is a rare, progressive, debilitating neuromuscular disease. And of course, the fact is that we have motor neuron death, progressive muscle denervation, skeletal muscle atrophy, overall weakness, loss of motor function. And of course, they will cause, in the severe case, pretty close to death after 1 or 2 years of the evolution of the disease. And so far is considered one of the leading causes of infant mortality. And of course that we have all these things that happen in SMA, like repeated episodes of pneumonia, difficulty with sleeping and nutrition, need for respiratory, nutrition, and orthopedic, reducing all these things' quality of life. The fact is that during a long time, we have this classification, what we consider as a classical classification of SMA, in which we have really very early onset, that type 0 that is neonatal onset, that is congenital, but really starts clearly in the prenatal stages, and the most severe after birth one, that is the type 1 disease. And we have the late onset, where that's divided in type 2, type 3, type 4 disease, depending on the age of onset and the major motor milestones. We can clearly say that we can say a functional classification in non-sitters, sitters, walkers, and long-term walkers. That will be probably the most clear classification to initiate the introduction to SMA. But I know, and you know, that this is really what is evolving because of the different treatments, and there will be probably different types of phenotypes that we're going to see later. This is a typical patient with type 1 SMA. Please don't take pictures of the baby. And the most important thing is that this is floppy baby syndrome with muscle weakness, poor head control, belly breathing, bulbar muscle weakness. We have weak cry, difficulty in swallowing, and aspiration. And the most important thing, they will never sit unsupported. And more than 90% of these cases die at age of 2 years. That's what's happened with the natural history of the disease. Of course, that this is caused, as we mentioned in my previous conference, that is 2 identical genes, but one is lacking, that is SMN1, that is able to produce most of the protein function that is needed in the disease, and SMN2 that is present in all patients, and they have only a part of this protein that can really be functional, meaning that the disease is caused not because of lack of protein, but because there is less functional protein. So the fact what we need with the therapeutic option is just to increase the amount of complete SMN protein. And the experience, the primary manifestation of the disease, we mentioned that is the weakening of voluntary muscles. That's the reason that the patient is derived primarily to neurologists. But the experience of patient is dominated by the downstream complication. That's the reason that we need a pulmonologist by compromised respiration, a nutritionist because impaired nutrition, an orthopedic specialist because of the deformity of columns and hips, and limited functional ability that makes that the rehabilitation for physiotherapists can be for always a measure that can be followed in a multidisciplinary team. That's the reason that mainly SMA is becoming one of the first diseases in which a multidisciplinary team was taken into account. This is for you to remind that The full-length SMN protein is produced from the SMN1 RNA, and we see that in the presence of a C here is the difference with the SMN1, and the presence of a T here is present with the SMN2, and that's means that there are splicing error in most of the transcript, but when there is not SMN1, there is a way to try to survive of the cell, making the inclusion of exon 7, even though it's not sufficient to avoid the disease, at least to maintain the cell alive for a while in all bodies. So this is a summary that we can really deal with the continuous spectrum of phenotypes in SMA. All patients have SMN1 absent or pathogenic variants. The SMA types from 0 to 4, and the manifestation will depend on the number of SMN2 copies and the amount of SMN protein. And of course that we are still looking for positive modifiers or negative modifiers that in the same number of copies there will be patients with more severe phenotype or less severe phenotype. Concept to take into account about SMA therapy. Non-modified disease therapy should be indicated with a categorical genetic confirmation of the disease. We need to have the 2 alleles of the SMN1 gene deleted or mutated just in order to indicate the therapy. Otherwise, we are dealing, what we mentioned in my first conference, with the possibility that the patient with 1 copy, and we don't know what's happening with the second copy, could be a carrier of the disease by chance and will have another neuromuscular disorder. And the second major concept is that non-modified disease therapy should be indicated without ensuring that there will be a multidisciplinary follow-up and the application of a standard of care. We will discuss later that in any patients that I have seen during these years of treatment with any therapy, if they have a good nutritional status and they have a good respiratory care, the patients that will really have a much better outcome than the patient that they don't have really a multidisciplinary care or they don't follow the standard of care. So this is the therapeutic strategy that we know in which we have to include the exon 7. We have an antisense oligonucleotide that is acting in the intron 7, and we have a small molecule Evrysdi plant that acts at the end of the exon 7 and at the beginning part of the intron 7. So if we see what is the mechanism of action here, when we have reinforced this mechanism of making the union between in the 5' splicing site of the exon 7, and it has also influence on the exonic splicing enhancer 2 in the exon 7. With these 2 places is good enough just to make a reinforcement mechanism in which exon 7 will be coupled with exon 8 and can be included in the final protein. Here is depicted the place in which nusinersen 18 nucleotides is hybridizing by antisense nucleotides. So means that even though the mechanisms are similar, they are not the same. And that makes that with time, we can consider that when you produce that, we should probably think that there are different mechanisms of action, but at the consequences are the same. But we have to know that nusinersen suppress an inhibitory mechanism by the fact that this oligonucleotide just really take away these inhibitory proteins, and Evrysdi plan reinforce a forward mechanism in which exon 7 can be included to exon 8, reinforcing a physiological mechanism that is including the exon 7. Having this into account, I have to stress also that this is a way in which we see the trajectories and main classification of SMA. And you see here in green that is the normal trajectory in the evolution of a person, and in SMA that is related in all these different colors. Below this, what we consider the therapeutic window. Doesn't mean that the therapeutic window will not be later, but the chance that you have better outcomes and better response when the disease already started are less important than when you have really the pre-symptomatic phase. And of course, we define the type 1 disease as an acute phase and subacute phase, and moving to chronic phase in patients with type 2, type 3, and type 4 disease. What I want just to stress here is that even though we consider always type 1 disease an urgency in the treatment, when we have a type 2 patient that is losing motor neurons like in here, a type 3 patient that is losing motor neuron like in here, or a type 4 patient that is losing motor neuron like in here, I also consider this an emergency situation, because it's the best way in which we can really rescue the motor neurons of all these patients in order to try to avoid what is called the progressive decline of the disease. Because if we don't treat that, we are going to treat a patient that is much, much more affected later in life. So I think that we have to take into account that we have three important things to consider in the treatment of the disease. First, try to get as early as possible. Second, in a patient with 2 SMN2 copies and signs of the disease before the 3 months, just every hour counts, because every time we lose a motor neuron. And patients with type 2, type 3, or type 4 disease needs urgency treatment when we see that this patient is losing the abilities or the functional abilities that they have. And this is the different way in which when we affront the treatments, we can have different ways depending if we do pre-symptomatically or we do what after symptoms. And after symptoms, we can have different evolutions in comparison with the pre-symptomatic, in which they are very close to the normal evolution. What we means that we want to cure or to have minimal manifestation of the disease. But it's clear that when you start the treatment, when there is manifestation already of the disease, we will have different types of SMA, probably related with the time in which you started the therapy and the number of SMN2 copies, and of course the different complications that may appear. What we see that, for example, stronger type 1 patients that are becoming after treatment may improve the motor, but not sometimes is not parallel with respiratory or even bulbar or nutritional status, and always will develop scoliosis. And we see that type 2 patients, they will have fewer complications. Perhaps they will not develop scoliosis so quickly, but they will be crawling and standing, walking as a type 3, but with the scoliosis later that started as a type 2. And of course, with the stronger type 3 patients that they are permanent walker, we can make a permanent walker if we treat this patient, and we have improvement and maintenance of walking abilities. Sometimes it's not a case of how, if the patient is walking or not, how is walking the patient. It's important also to treat the type of gait that the patient has. They will improve with the treatment. So we move here from simple hypothetical considerations to real observation in clinical practice, and we are having a mix of different nutritional, respiratory, motor function, and orthopedic features in all these new patients after treatment. And we cannot say that all the patients will respond the same and all patients will evolutionate in the same way. It depends, of course, of the type of standard of care, of the type of medication, and when we start the medication. Another important issue is that, can you consider that SMA is really exclusive motor neuron disease, or we have also affectation of other organs? It's clear that there is some organ involvement, particularly more pronounced in type 0 disease, in which we have cardiac disease, we can have brain manifestation, we can have vascular manifestations. And type 3, we can say that it's more purely neuromuscular. However, between that, we have different type of patients that may be related with different things. Here, the figures that not appear for, I don't know why, but we can say brain, lungs, heart, muscle, bone problems, and blood vessels, and problems in the gastrointestinal tract, in the liver, or in the pancreas. All they were considered with the mouse model, and some were seen in patients, particularly in patients with severe disease. So the more severe is the patient, the most probability that besides a problem in the central nervous system, they will have a peripheral problem. Even neuromuscular junction and muscles should be considered outside of the neuronal issue, even though they form part of the same neuromuscular unit. And the thing is how a therapy can reach really muscle and neuromuscular junction if we give this therapy, for example, only in the central nervous system. This is something that we have to think, and all biodistribution of a general therapy along the patient, in the body of the patient, means that this is a rational approach to be considered. And of course, the earlier we do the treatment, the best we were going to get the pre-symptomatic, catch the pre-symptomatic or early symptomatic patients. The fact is that when we have a newborn screening in the future, we are going to have much more pre-symptomatic patients, and with the evolution of these pre-symptomatic patients, we are going to have less hospitalizations, a better and best healthcare things for the system. And we still will have some historical patients that will appear or symptomatic newly diagnosis, because the newborn screening will cover only 95% of the cases with homozygous deletion of SMN1. There are still 5% of cases that will come because they have a deletion in one allele and a point mutation in the other allele, or 2-point mutation depending on the consanguinity of the parents. What is in this moment, we have a movement that we call the SMA Newborn Screening Alliance, in which the lemma is there is no more time to base for babies born with SMA. Newborn screening programs for SMA in all European countries no later than 2025. Hopefully, this will be taken as a model also for other countries, because it is clear that if you start a treatment at 1 month, instead of wait until 5 months that the patient becomes just really symptomatic, the evolution is totally different. And we are going to see this in different aspects lately. Regarding the burden of the disease, we know that SMA has a wide societal impact due to the loss of the motor function. And of course, affects not only the individuals with SMA, but also the families, the healthcare practitioners, and the whole society. Take into account that these patients, when you improve the motor function, they could be really ascribed to the society to be useful, and they can be professors, teachers, or can be really, I have patients that are chess champions, that paint, that write books. So there is a different interaction if we can really improve the motor function of these patients. On the other side, we have to take into account that in the more severe cases, probably we have to see if there is some compromise of the central nervous system, or some compromise like autism disorders or intellectual disability in the future. So these are all challenges that we face. Should we treat this patient as early as possible and see how is the evolution? And we are learning every day when we treat the patients. There is not still a protocol, there is not still a manual. We are learning at the same time like the families and like the patients. And of course, SMA meets the World Health Organization criteria for a screening program, because we know the knowledge of the disease, we know the disease, we know the test, we have a treatment, and we have to get the cost consideration. As I mentioned, if you treat a patient with 5 months because you have an approval of a therapy, why don't treat the patient at 1 month when you know that this patient has less manifestation and there is more motor neurons to be rescued? Because the motor neurons die day by day, day by day. So this is the most important thing that we have to take into account, and that's the reason because the patients that are in the pre-symptomatic trials get much better evolution than the patients that are from symptomatic trials. And of course, the real-world evidence that gives us the reason that we have to treat this patient as early as possible. And which are the ways in which we can really get these patients? We can have a prenatal screening because we know that there is a previous case in the family, or for any reason. For example, in the United States, they offer to the pregnant women to have a prenatal screening for homozygous deletion of the SMN1. We can get this patient also for newborn screening, or we can have a population carrier screening with premarital tests identifying couples at risk. There are several ways in which we can anticipate to the occurrence of the disease. The decision is after of the couple, but we have to offer the couple the alternatives, that this is a frequent disorder, that can be treated, and of course, we need to inform that. In Australia, there was an anecdotal case. There was a couple that had a child with SMA, and the nuns make a judgment to the government because the government knew that the carrier screening could be available for them. And after that, they put population carrier screening to all the country. So that means that we have to think about that in a way, in a prevention way, to anticipate the occurrence of the disease and to inform and communicate the family as best as possible. Can you imagine that you suddenly have a baby with SMA and you don't know nothing about the disease? If you know the disease, if you have information about that, you can make better decisions, and even better decisions about the treatment and about the future of the babies. And of course, this is also supported by financial cost on quality of life. In this paper from Tamara Dagonlov, she did the PhD thesis on these topics about the cost of newborn screening, because she's basically an economist, and he was working with Dr. Servet and Francis Womer, that is a geneticist, and Lawrence Servet, that is a pediatric neurologist, about the possibility when you have no screening or no treatment, really these are the medical costs, and these are non-medical costs and the loss of productivity. When you add the treatment, you spend a lot of money, of course, in the treatment, but you still have medical costs and non-medical costs and loss of productivity. The best scenario is that when you have a screening and treatment, you can spend money in the treatment, but you reduce the medical cost, the non-medical cost, and the cost of screening is really a tiny portion of we can add to the expense of these studies. So the conclusion is that early patient identification and treatment offer the opportunity to reduce the total societal cost of SMA, where treatments are available for pre-symptomatic and post-symptomatic patients. Has no really sense not to treat patients pre-symptomatic when we have symptomatic treatment approved. So I take a brief, and we change now in this part to the program of Evrysdi that have been developed during the last years, in which we have different clinical trials: Firefish, age 1-7 months, inclusion for type 1 SMA; Sunfish for age 2 to 25 years, type 2 and 3 SMA; Jewelfish, age 6 months to 60 years for all types of SMA, previously treated with an SMA targeting therapy or even a neuroprotector like Olexosyme; and Rainbow Fish, that is age 0-6 weeks, genetically diagnosed with SMA, but not yet with presenting symptoms of the disease. We are going to dive a little bit on the Rainbow Fish, that is the treatment pre-symptomatic clinical trial, and Firefish, that is the symptomatic with babies between 1 and 7 months. Starting with Rainbow Fish, is that have been included because the observation that I have been really tell to you that there is a severe denervation during the first months of life, and they'll need really to support the motor unit loss, and they will probably rescue as much as possible these motor neurons. Remember that the disease starts in utero. You start to lose motor neurons in utero. And when a baby is born with 2 SMN2 copies, has half of the number of the motor neurons that the normal baby. However, this half number of motor neurons, they are still rescuable. That's the reason that the patient is not yet having manifestation. But something happened, that these motor neurons start to be dying, and this is the way in which we should probably treat these individuals, and they will be critical to avoid the irreversible motor neuron loss. And the study population was the genetic diagnosis of autosomal recessive SMA, in this case, homozygous deletion of the SMN1 gene, absence of clinical signs or symptoms of SMA at screening, and up to 6 weeks, 42 days of age at the time of first dose. The primary analysis population was the infants with 2 copies of SMN2 and CMAP amplitude more than 1.5 at baseline, and to see the proportion of infants who are sitting without support for more than 5 seconds at month 12. And there are different secondary endpoints that we are not to discuss that, but still there's not complete information on that. So they started the rainbow fish, and of course, that was important to do the rainbow fish to have a previous study of 2016 in which that was done in natural history to assess the motor function and possible electrophysiological protein and molecular biomarkers in infant ages less than 6 months with and without SMA. That have been published by Kolb et al. In Annals of Clinical Translation in 2016. And this study was useful when designing rainbow fish, as provided several reference values for the things that I'm going to tell you now. There were key inclusion criteria and key exclusion criteria, but the most important things that were mentioned before, there will be not really particular signs or symptoms that are strongly suggestive of SMA prior to dosing. And the key exclusion criteria was the patients that had been with respiratory problems, in particular with invasive ventilation or tracheostomy. And of course, how we get these pre-symptomatic cases. The most important source of these pre-symptomatic cases was for previous history by prenatal screening or immediate neonatal screening because there was a case on the family, or you can have some cases by newborn screening that are detected as pilot programs in different countries. And this is the population with the baseline characteristic, as they have, let me see, and we have more, oh yes. We have, this is important to know that the age at first dose was 26 days with extreme of 16, range from 16 to 40 days. The SMN2 copy number were two copy number in 7 patients and 3 in 11 patients. There was more or less the same sex ratio. And as I mentioned, by newborn screening, we detected 13 patients and 5 patients by family history. And what is important also that the baseline value was less than 1.5 millivolts in 3 patients, that we suspect that these patients could have some very early manifestation of the disease, and the baseline value in the remaining patients was more than 1.5 millivolts. That should be considered at that time really particularly compatible with normality. Actually, at the time of Rainbow's data cutoff, 7 infants had been treated with risdiplam for more than 12 months. And we are going to present the data of these 7 infants with 2 copies and with 3 copies. You see here, for example, how was the chopping 10 evolution, in which we see that the patient with 2 copies started, remember that 40 is considered the value. One of the patients was really involved with lower values of chopping 10, but not really very bad, but was less than 40 and start to increase after the treatment. And you see that all the other patients have more than 40 that is considered a value that is compatible with normality. And you see all the patients with more than 2 copies, in this case the 3 copies, all these patients were above 40, and they maintain and arrive to the limit of 64 in all cases. And here, with some exception, practically also they were close to 64 in most of the cases. Here you see most of the infants treated for more than 12 months achieved motor milestone within the World Health Organization. And this is seen here, in which you see the patients sitting without support. You see patients crawling on hands and knees, patients that standing unaided, and patients that walking independently. And the patients with 3 copies, they are all practically within the range of the World Health Organization, with the exception of these 2 cases that were seated at month 9, but most of the other ones were just reaching these motor scales really within the range of normality. Going back to the other one, you see that there are some cases, in the cases with 2 copies, that are here, but there are still waiting for some cases that will develop the normal range. But we can say the patient with 3 copies develop that. What is the importance of this one? If you have a patient with 2 copies and you treat pre-symptomatically, still there will be the possibility, because the disease started in utero, that the number of motor neurons cannot be totally rescued and recovered. But however, a patient with 3 copies will have more than the 50, and all the neurons can be rescued. That's the reason that these patients can run after 3 or 4 or 5 years of treatment. I saw patients with 3 copies that has a previous sibling that was a sitter, that was not able just to stand up, and the sibling that was treated running, exactly with 3 copies and with the same homozygous deletion. Another aspect that we have to take into account is the swallowing and the feeding. You see that all infants treated, these 7 patients, maintained the ability to swallowing, the ability to swallow solid food, and the ability to feed exclusively by mouth. So this is a very important thing, because when we have a patient that already started manifestation, there will be a bulbar component that makes them very difficult and to have, the autonomous for be feeding by mouth, and you need to use a nasogastric tube or even sometimes gastrostomy. This is important because you treat these patients and the bulbar function is maintained, and you can really give a much more quality of life in this case, and the patient get the nutritional status as best as possible. And there is other thing important, that no infants who were treated for more than 12 months required permanent ventilation, and no infants who were treated for more than 12 months were hospitalized. That means that the curve that I show you with PS, that is pre-symptomatic, close to the normal, is really very close to the real world evidence of what's happening with these patients. Regarding the adverse effects, there will not be really a specific adverse effect to be worried, and particularly I want to tell you that the adverse effects, there are practically the same between patients with 2 and 3 copies, with the difference there are some probably respiratory infection more banal in the group of 2 copies. So a summary of this trial, as for February of 2022, the worldwide recruitment for rainbow fish is complete. Of the 7 infants who were treated with risdiplam for more than 12 months, most achieved motor milestone within the World Health Organization window for healthy children. Most reached near maximum chopping tender score by 4 or 5 months of age. All achieved sitting without support by month 12. All maintained the ability to swallow and were able to feed exclusively by mouth, and none required hospitalization on permanent ventilation. Furthermore, no serious adverse effects were reported in the pre-symptomatic infant treated with risdiplam for up to 20.28 months. And this is because it was related to the dose that had been approved to the FDA for infants that is less than 2 months old. Let's talk a little bit about firefish. And in the firefish, there was a screening by enrollment criteria. There was a genetic diagnosis of IQ, symptomatic type 1 SMA. We have a different population here. We have a population in which the disease is already there. We don't have to look for a genetic test to diagnose the disease, but we already know that the patient is telling us that has SMA, and we have the test, and we test for 2 SMN2 copies, and we put patients between 1 to 7 months old. Some started the disease early, some started the disease laterly. And of course, we are going to follow different parts, but I'm trying to be clear what the open label extension entry after 24 months of treatment. We have results now. We used to have the results of the month 24, but now we have opened the new results for month 48 during the last years, and we are going to discuss a little bit the results. So these are the different characterization of the populations that we have here. What is important is that we have different patients depending on the part 1 or part 2, and the total infants were more or less distributed. And at onset of symptoms, there were probably 1.5 more or less in all these cases. And at enrollment, there was around 6 months, 6 and 5 months. And the disease duration until the initiation of the therapy was around 3.4 months. And the motor outcomes median scores, you see that is less than 40, 24, 22, 23. And the highest score, there was around 1, no more than 2 in all the cases. And with this clear, when you see the natural history of happening type 1 SMA, because different study, previous study, that 81% of children were event-free after 48 months of treatment with risdiplam. So this is an important measure on the population that we follow after almost 4 years. And what is related with motor function, with this was the crosscut at month 24, and that's what we see now at month 48, in which 64% of the patients, they're sitting without support for at least 5 seconds or for at least 30 seconds. 3 of 58 are standing alone, and 1 of 58 is walking alone. Remember that without treatment, children with type 1 SMA are not able to sit without support, and not even standing on or walk. The results on the Hinem motor scale is more or less the same at the month 48, in which we have patients with head control in 67% of the cases, includes stable sit and pivots rotates in 57%, rolling supine to prone in 45%, standing 16%, and walking 12% in the total enrollment of the cases. And what is important to see here is that, I want to show you this slide, because in this slide you see that the patient starts with a mean CHOP intent total score that lower than 40, and they will reach almost normal values after 15 months in most of the cases, and they're still improving after time. So this is something important that we have to take into account. We cannot expect an immediate result or an immediate response of the patient, even though some hint to scale that will appear. For example, a patient will be able to have head control, a patient can be able to sit, but perhaps the other scales, like in this case, the CHOP intent that is used, will take some time to be improved. This is to be taken into important because health authorities are very jealous with the evolution of the patients, and they want a response very clear, very early, and very, very precise. And sometimes we have to be patient because not all patients will respond in the same, as you see with the standard deviation that we see in the CHOP intent in these cases. Of course, there is another issue that is important even in the population that manifests the disease, that's swallowing. and feeding abilities were maintained by the majority of children from month 24 to 48. And we see here that the ability to swallow, the ability to feed, they will maintain in the high percentage of these cases. Another issue that is interesting is that the rate of adverse effect declining over the 48 months in children treated with risdiplam. You see that the amounts when the patients get used to the medication, little by little is appearing less adverse effects. And we see here in particularly serious adverse effect in which pneumonia also get low here. There is a small increase here that we consider that can be probably for the relaxation after the COVID studies, and the other will be that start again, to be infections between families and patients. And this is interesting to take into account that, little by little, the adverse effects is as happens with most of the medication that we have. We start to treat the medication and it gives us, for example, headache. I take something for my pressure, and I spend the first 2 months with headache and almost fainting. However, after a while, we get used to the medication and the adverse effects just disappear. And something happened with most of this, is having this rule in a different dimension, but we have to take this into account. We need to give time for the adverse effects. We need to give time to the outcome. And also here is that hospitalizations decreases over time to 0.63 in the month 48 in comparison with 1.124 in the month 12. So, having an overview of the 3 medications, we now, in the scenario of SMA, we have risdiplam that we have mentioned, that is a small molecule given orally, and there is including exon 7 in the mechanism of action that I mentioned before, and it's a daily treatment. We have nusinersen, that is a medication that is given intrathecally that promote also exon 7 inclusion by a different mechanism, even though the results are the same, that is inclusion of exon 7, that this is distributed the majority in the central nervous system only in comparison with the distribution throughout the body. And the treatment needs a loading dose of 2 months, and after every 4 months repeating administration. Finally, the gene therapy is the recombinant AAV9 based gene therapy that is you give intravenously, and this comes an episomes in the nucleus and have an autonomous replication and performs SMN product from SMN1. Remember that it's not the complete gene, but only a short part of the gene that is only related with the cDNA, that is the transcription part of the gene. And of course, they have different issues regarding, because it's one shot, you have not to have anti-AAV virus in the patient, and you have to take different monitoring assessment on pre and post intravenous administration, particularly following up of liver problems and increasing of transaminase. So we have an interesting scenario of treatment, and of course there is always room for combination in the future, because we know that we treat the patients, perhaps the cure is not absolute, particularly in the cases when we start the treatment after symptoms. So this is open to debate, and we can discuss later. Here there is a comparison. Study has been published, the comparison, the 3 medications, and there is some issues that can be related with prolonged event-free survival in patients receiving risdiplam in comparison with nusinersen. And also, there is a suggestion that treatment with Evrysdi versus nusinersen is associated with an improved 3-year outcomes in type 1 SMA. I suggest you to read this publication and make your conclusion, but things that at this point is very difficult to make a comparison, head-to-head comparison, because the populations were not exactly the same, even though they can have indirect comparisons. So I want to show you a 5-fish case presentation. I know this case since from abroad, from a colleague that had been following this patient during the first times, since the first time. The diagnosis was made after 3 months, because was born in 2017, and the first symptoms appears after 2 months. Have 2 copies of the SMN2 gene, and at 5 months started the therapy with Evrysdi. And this was happened at 10 months, was sits unsupported. At 13 months, she moves around independently in a wheelchair. She stands in the upright at 18 months, and after 2 years, she's able to do the first steps with 8. And this is the, let me see what is here. Okay, this is the evolution of the chopping 10 of these patients. She was diagnosed with a chopping 10 of 12 at the age of diagnosis, and now she's after 5 years with the chopping 10 of 58. And I'm going to show you some interesting videos. These are the most updated videos for the patients. When we see the patient walking with support, oh no, let me check. I think I have to do this manually. I do him back, but it's not coming back. Let me check. Says thank you. Very quick. She's ashamed to show the videos. What we have to do? I'm going to take some water now. Cheers for you. You take advantage and take a little bit of water now. This one. Okay. Okay, now I will do that. So here we see the patient walking with support. She's now almost 5 years, and she's doing very well. Even the dog, I recommend that a dog is a good company for these children. See details. You know, she has always something, because they can have deformities in the feet, and they can be deformities also in the hand. And you have to take into account that he has to be followed by possible scoliosis. Because this is a patient that has been treated not pre-symptomatically, but after the symptoms. Look now, she's standing unaided. She's not doing a step, but she stands unaided, and he used some things to help her just to maintain and to make the draws in this way. And finally, and because swimming and to be in the swimming pool is one of the best exercise, because you confront the gravity, and when you are, it's like when you are in utero with your mother, you know, you can move without any special problems, because you have the water and the gravity is different. But here for them, for all these patients, this is a beautiful exercise, and see how she's able to swim independently. You see in the back, there is a rehabilitation also of another patient. But these are examples that these patients can be treated even earlier, because she was picked at 5 months of treatment. Can you imagine if we started the treatment, for example, very early, before 42 days, she will be to walk or to run around and to have a good evolution. So that's the reason that we have to really be aware and to be in our philosophy that we have to treat this patient first as early as possible, and secondly, to treat, to make a diagnosis. Perhaps sometimes it's better to have a test, an additional test that even is negative, that not to think that the test will arrive very late for these patients and to decide the treatment. So, conclusion, that Evrysdi is life-saving for type 1 SMA because there was no deaths related with these patients. Evrysdi has proven efficacy and safety sustained for up to 4 years, and over now 11,000 patients are treated worldwide to date of different ages, not only pre-symptomatically, but also children, infants, adolescents, and adults. And they told me, I didn't know that, so they put that there. It's the only registered medication in Egypt for treating SMA. So my things giving you the thank you. It's just to open the discussion, but what is really important to resolve is the possibility to make early diagnosis, early possibility of treatment, and early communication of what is the disease to the family. I open now to discussions.
Good evening, dear professor. Thanks for being with us for the second year. I have 2 comments or 2 questions. The first one regarding the case you mentioned. You mentioned that the case was treated when she was symptomatic. But I have a comment regarding the scoliosis, because we know that scoliosis mustn't exist at an early age as she started treatment. Do you think that the treatment has successful result, although with the development of the scoliosis?
This is a sort of discussion that we have with different colleagues around the world. Scoliosis, paravertebral muscles are more sensitive and more difficult just to respond when you compare, for example, with the head muscles, or when you compare even with the hip muscles or with the legs muscle in these patients. So the fact is, that's the reason that the scoliosis appears in the vast majority of the patients with 2 copies, type 1 disease, and you treat symptomatically when they are already symptomatic. I know that there are, under clinical trial, in this moment, there are being followed more or less 40 to 50 patients that have been treated pre-symptomatic, more than 40, almost 60, and there is no report of scoliosis in these patients that have been treated real pre-symptomatically. However, I know that some patients are born with SMA. There are some symptomatic, subtle symptoms, but they have some type of column deviation. And this is an effect that we have to follow and we have to look at. So I think that scoliosis treated pre-symptomatically can be avoided in most of the cases. However, there will be exception of these cases that can be also early develop scoliosis before the patient gets the seat. Because another thing that is important, that patient gets kyphotic. However, in this case, the patient was not kyphotic. She's a very good responder of the medication, and she's very good. I don't know, I would like, for example, to study her 2 SMN2 copies in order to see how strong or how good are these 2 SMN2 copies, not to avoid the disease, but at least to have a very good response for the treatment. But I have to say that scoliosis still is a matter of discussion all over the world, and we know that we cannot avoid scoliosis in patients that are treated symptomatically with 2 copies in most of the cases, but scoliosis can be avoidable or even delayed when you treat these patients pre-symptomatically.
Okay. Second question or comment regarding pneumonia as adverse effect. It is well known that pneumonia will come early because the patient has the severe symptoms early. Is this, from your point of view, ways to complete Evrysdi even if they experience pneumonia, or we can shift or combine with other drug to bypass the age and reach them with the age when the pneumonia will decline?
Yes, the first 2 winters of the patients are very important. And depending when the patient is born, we have to take into consideration several other measures. I was discussing with the colleagues the fact that during the first year of life, there is important to rescue as much as possible motor neurons, and they will help us to develop much better the neuromuscular junction and the response of the muscles. So I will not discard the possibility that in the future we will have protocols, at least for the first year of the first 2 years of the disease, particularly in patients with 2 SMN2 copies, that you have to do a combination of therapy or as much therapies as possible in order to avoid the consequence later in life. And pneumonia is not the exception, because pneumonia is the result of bad aspiration, problem of swallowing, and there will be also a problem. When we were in the COVID, and you probably will have the same experience, patients were very well because they were all the time at home. Parents were all the time washing their hands, following all these measures, and the patient was barely infected. And there was a coincidence what we are showing here. It is possible that we will see in the future if this is really continues to be a measure, or there will be an artifact related with the COVID pandemic. But in my opinion, the best we manage from the physiotherapy, the best nutritional status is, the less infection will get the patient.
Thank you.
Professor Tizano, we started to therapy in some patients, Evrysdi in children and adults, but I observed that there is a variable response from patients. Although it may be the same time, age group, and even number of copies, but I found one patient very good response and the other no. This occurs in children, and also I have 2 patients, adults, with the same clinical picture. One gave very good response and the other no response. What do you think about this?
How old are they?
For the adults, they are in the 30s, type 3, and they have 3 copies of SMN type 2.
And they started the manifestation of disease at the same time? Or around the same time?
The one gave a very good response, has manifestation since he was 1.5 years old, but continue walking until 30s. And the other one is the same. The one who responded, I even presented his clinical condition in some conferences. After 6 months, he gave good response. After 1 year, he became walking without support. He was walking with support. But the other one, still the same. Okay, there is no deterioration, but he is the same. Didn't give me a response.
So what was your expectation when you started to treat these patients? To improve the walking? Because if these are type 3 patients, they were walkers.
Yes.
So how was the gait? Was a bad gait? Because you have to take into account what was your expectation. If both patients have the same problem and the same gait that is unstable or a little bit walking that, you have to think that perhaps that's the thing, that if one improved the gait and the other not, that's what's your concept of no response.
I want them to be independent, to walk unsupported. I want them to, I'm expecting not to treat the weakness so much, but I want them in this stage to walk without depending on any other. So I'm searching for independence. The first one became independent.
Okay, and how is the gait? Because this is another thing, because
okay.
it's not the same that you say, okay, he becomes independent, but he's still working with problems.
Of course, of course.
And we have some patients that are walker, start the therapy when they are in that way, but they're walking after the treatment like that.
Okay.
So this is one way you can see the response. You know, the response is not that the patient is sitting and after become a walker. The fact is that these patients barely can stand up. They need to help to that. And when you give the medication, this patient became more independent. And you find one of your patients was independently walking now. But how is the gait?
Gait still waddling gait. Still
Another thing is male or female? Both females?
Both are males.
Both are males. This is another thing that we have to take into account. I think that there is a lot of variation in that. One of the things that we have been looking is the sequence of the SMN2s of these patients have difference in the place in which Evrysdi plan or Spinraza will act. And so far, we were unable to see a difference. That means that these sequences are very conserved between the patients. So seems not to be related with the sequence or the place of union of the medication. But so far, we don't know yet what other factors could be in that way. I hope I will have the answer in the next times, in the next years.
Okay.
But so far, we need to collect these observations, and we have to study these patients more in deep in order to see how could be the baseline of the patients that could be the same. Nutritional factors are the same. They will maintain it in the same way by physiotherapies. How about the contractures? How about the stretching of these patients that they do daily? You know, how is the nutritional status? So there are a lot of differences that can be taken into account, and we don't know yet what could be the cause.
I agree with you. Maybe the multidisciplinary team, one of them is very enthusiastic in the physiotherapy and hydrotherapy, and others, he said, I do, but I think that he didn't do the effort that is needed.
And finally is the psychological issue.
Yes.
We have to take into account the psychological issue that you receive a treatment and some patients get positive to that, and some patients probably, they say, okay, there are more reluctant and there are more pragmatic. I told you, passionate patients and pragmatic patients. You know, pragmatic patients is, oh, you give me the medication, but I feel the same. And passionate patients, oh, you give me the medication, I feel enthusiastic, I can do things that I can do, I can walk more time or whatever. Sometimes, you know, the mind helps a lot in the results, or at different times. And my second question is, for how long have you been treated these patients?
Both of them, 1 year.
1 year?
Yes.
Wait a little bit more and see what happens.
And I have a question in a genetic diagnosis of a patient. He is type 2. Clinically, he has SMA because he has the fasciculations, the tremors, the weakness, the loss of reflexes, and neurophysiologically, he has anterior horn cell disease. Mother and father are consanguineous, but he is the first child to them. He's 5 years now. We did for him the MLPA, and it showed that he has 2 copies of SMN1, very good, no mutation and no deletions, and 3 copies of SMN2. But still, what I will do now is SMN...
You have to do the sequence of the SMN1.
SMN1, or I will do the whole exome.
No, do first SMN1.
SMN1.
Do the sequence of SMN1. That is cheaper than exome. If the sequence of SMN1 doesn't make you any specific thing, because this is a consanguineous family, it is possible that a rare mutation can be involved in that, and that's the reason that the MLPA gives you 2 SMN1 copies. So I suggest to do the sequencing of this case. I can help if you need help. I can do the sequence if you want, no problem. We can arrange that.
Maybe this child will need your help, because I will follow up if they did sequencing for him and it was negative or not, because he has the manifestations and the neurophysiology.
Of course, and you need to give the treatment. you
Yes,
have to
yes,
confirm
yes.
the disease, otherwise you never
This is the
know that the
only
disease
child.
is there.
This is the only child.
So
The-
let me know, I will try to help as much as possible.
The last question, I'm sorry, about newborn screening, because we face trouble with Professor Murad Al-Alfi with the MOH. When we told them 1.5 or 2 years ago, we want to do newborn screening and keep the money for the asymptomatic, they refused. And the cause of refusal that you will diagnose more patients. You will diagnose large number of patients, and some of them will need therapy for life. So how can I convince them about newborn screening?
No, the fact is, if you treat a patient with this symptomatic, when you show in the same family, I don't have the videos here with me, but I can show you the same family, a patient that had been treated
You showed us
after
before.
symptoms.
You showed us last year.
I saw you last year, no? A patient in the family had been treated of 7 months, I think, or 6 months of age. Yes, and he was not only tracheotomized, but also able just only to sit. And the brother that had been treated at 21 days was kicking a ball. Remember the kicking a ball? Okay, so when you show that to authorities, they will not doubt that there is a different quality of life. You can spend less money on health care, and you will have much more quality of
They are
life.
thinking about paying money for therapy.
But the problem is, if you pay, it's like say, okay, don't pay now, but pay in 5 months. But in 5 months, you start to pay, but you continue to pay and to spend more money in health care. But if you pay now, you save, you spend 5 months of more money, but you save later. That's what I show you in the scheme. You know, when there was the paper about hospitalization and about all the expenses that we have. So I think it's a way, and we can support you by our European alliance if you want, because this is difficult, even for Spanish authorities. It doesn't mean that I could convince the Spanish authorities, even though I speak with them very frequently. You know, this is a problem of economy. And in the economy, you have to put that the health of the patients in the future, they will save you your money in the future. But unfortunately, politicians just say that the end of the year is 21st of December, not what's happening in the next years.
Thank you.
But count with me also to do that. If you need to speak with the health authorities,
Yes.
we can
We
help
have- we have troubles.
in name of the European Alliance,
Yes.
in order just to help you to make decisions.
Maybe we can
or at
have
least to
the
support.
European Alliance guidelines, so we can try to
We
convince them.
we have a white book online about that, giving you all the explanation, all the advantage, all the problems that we have, but at the end, the final results is that this is very important to implement everywhere. And you see everywhere that more and more countries are implementing newborn screening.
Thank you.
I can sit with you if you want.
If you
So we can have a shared session in that way.
if you allow, just I think this is very important point. In our area or our culture, let the start to start. What does it mean? Okay, we can do because if I am in the authority and I have the impression, oh my God, if I have 2,000 patients, how can I manage? If I have 10 patients, I manage more. So let us do. We have to do the newborn screen. It doesn't matter if I do in the whole area or just select in high risk area. We have to accept. Okay, I am happy to do in the smallest country, in the smallest countryside, in the high risk area like in Bani Suef, like in Buhaya. I know in these two areas we have high numbers of SMA. We, as a committee, we will accept to start in very small area, high risk area, and do the newborn screen. And this is will most probably in the high risk, some that, and we can a very small number we can manage to diagnose and to after that to treat. if we do, the machine will work. I think gradually, we will see the financial and the cost benefit, and we can propagate the idea after that. So I think we have to start. You know, the Chinese sample say the starting of 1000 mile is only one step. يعني بداية انك انت تمشي 1000 ميل خطوة واحدة. We have to accept. What do you like? We will accept how to start. It doesn't matter how, but we have to accept the idea to start. And I am sure, few years, we will can manage the newborn screen as a routine in our country. I think this is the only way when you have talking in cost benefit or economy supported areas, but we are still are talking about a country like Egypt. It is the lead scientific country in the area, and at the same time 110 million personnel. So this is number we have to think proper to protect and to have less morbidity, not less mortality. So I think this have to start in this way.
Yes, you have to show, I think that you need to get the support of what is real world evidence that newborn screening is getting good. And doesn't mean that all newborns that you detect will be asymptomatic or pre-symptomatic. This is another issue that I want to mention to you. We have seen patients now that that have SMA, and you detect some subtle signs of the disease. So they will not be 100% pre-symptomatic 30 or 40% of the cases, but you catch the disease so early that the evolution of the treatment is much, much better than catching at 4, 5, or 6 months. Because the physiology of the disease or the physiopathology of the disease is you start to lose motor neurons in the fetal period, particularly in cases with 2 SMN2 copies, no? And you go this way all the time. And the sooner you get there, the more you can rescue the motor neurons that you maintain like that. If you catch these patients very early, than when still these motor neurons are still responsive to the treatment, you will have patients much more better, like the one that is kicking the ball that I showed you last year. In comparison with the brother that is still sitting like that and cannot really do a good quality of life in comparison with his brother.
Okay, something else, if Professor Nagias can allow me to say it, we can have the help and the support of the international companies to start it in very restricted areas like Novartis and Roche as well. If these two companies, or whatever the new company as well, added to us, we will ask them to cover this area, and who diagnosed can help in the management of this. This allow our government to start to think about the newborn screen as a part. I think we can start negotiations with my professor in this area. We can give a good start.
There is a publication in Lancet Child and Adolescent Medicine from the Australian group, and they were comparing the patients that had been treated by pilot newborn screening and in the same center with the patients that were treated without newborn screening. And the difference is absolute, and I think that this is a very important publication also to put as support of all the things. And the publication on the economical cost, this is also important. Because at the end, as I told you, it's that you have to change the roof of your house. Okay, let's put something and wait 5 months. But in 5 months, you have to spend much more money to change the roof.
Okay, sorry. Okay.
Many thanks for the two nice lectures. I want to ask, risdiplam is taken orally, and this is a very good advantage, but we have to take it daily for life. What happened if some doses are missed or lost, gastroenteritis or something like this? Will it affect the outcome?
This is something that, in this world, we try to put pros and cons of things. Oral medication is easy to give, But what if a patient doesn't like the taste, is having diarrhea, or is not with good adherence? Means that not every day, but, oh, I forgot to take the medication or whatever. That happens with all the medications all over the world. So my advice is that at this point, even we can have, if we want to assure that the first year or second year of treatment, the patient have all the doses, all the things I have, make a combination, for example. You can give Spinraza every 4 months and give the combination oral. I don't know, it's a problem of money. They will cost 1 cent or $1. Nobody will discuss which one we have to decide. But it's a problem of economical decision. We are thinking with the pocket. We are not thinking with the academic response. And that's the main problem now, that we are trying to survive in a bad situation. But in the ideal situation, I will propose that. To avoid problems of adherence, if you one day you lose the medication, don't worry, you have the other medication that also is supporting you. But at the end, the patient will respond much, much better. I hope I will die just having reason. And they say, oh, he was right telling that when you treat during the first years with all the medication, the patient gets much, much, much more better.
Okay, before closing the session, just I have a comment on the pulmonary function in patients of SMA. I have 2 children, 13 and 15. Both of them have SMA. They were frequently admitted to intensive care due to pulmonary insufficiency and pulmonary infections. After treating with Evrysdi for about 1 year, now they are not in need to admitted to intensive care for around 6 or 7 months. Evrysdi is really improving the pulmonary functions, even they are wheelchair till now. Thank you very much for Professor Eduardo. Thank you for all. Thank you for Dr. Nagia Fahmy. And we have to invite the next chairperson of the next session. Please.
Okay, thank you very much.